We can start.
Good evening, everyone. We welcome you all to OrthoTV, OrthoXpert Series. This is a new series which we have started to give the middle level and the young and dynamic orthopedic surgeons a chance to present their work. So today we are going to talk on a relatively new technique which has suddenly become popular in the last 3 years. It's called the direct anterior hip replacement. And today's speaker is Dr. Abhijit Agashe. He is a consultant joint replacement surgeon from Sayadri Hospitals and Sancheti Institute, Pune. This series is brought to you with the help of an educational grant by Haleon, the makers of Centrum Joints and Mobility. With this, I hand over to Dr. Abhijit Agashe to take us through the approaches and the way a direct anterior hip replacement is done.
Yeah, thank you, Neeraj. I think is my presentation visible now?
Yes. Can you speak a little louder? Thoda volume come.
Yeah. Is my presentation visible or is it my video is visible?
Visible. Both are visible. You can go ahead.
Okay. So, direct anterior approach, is it a new approach? The answer is no. Why have I shifted from my regular posterolateral approach, which I used to do for last more than 16, 18 years? And in the last, say, around a year and a half, 2 years, I have shifted almost 50% or more than 50% of my practice to DAA. The reasons are it definitely has a reduced dislocation rate. I can give a much better leg length correction. In the last 2 years, what we have found is the patient definitely recovers very faster, and majority of the times we are able to discharge our patients on the second or the third day. So this is just a small short video. That's the patient who can sit on the couch within 3 weeks of DA. And the next video is the patient who can sit down on the floor immediately within 3 months after a DA. And particularly in Southeast Asia and our country, our patients do have this requirement where we want to sit down on the floor. And that was one of the major reasons why I shifted to DA, because I could allow my patients to go down on the floor and sit on the floor. So if you see the literature, it definitely says that it has less soft tissue damage, faster and easier recovery, and low dislocation rates. But do we really have any literature supporting this? Answer is yes. If you go through the literature, you will find that there are a number of reports which say that DA has lesser dislocation rates, faster recovery, and definitely a much smaller or much lesser stay in the hospital. So is it a new approach? The answer is no in the described direct anterior approach. Definitely not described for arthroplasty those days, but he is the one who is credited for describing a DA in the first go. Later on, Smith-Peterson popularized it, not the right classical DA that we used, but the Smith-Peterson approach is the precursor of the DA that we use. Then Jude and Jude brothers used it for the femoral head without the approach. It was a failure of the material being used for the arthroplasty rather than the approach. Later on, Noel Mata from United States popularized the table and the re-interest into arthroplasty and using DA in arthroplasty. Also, one more surgeon, Mogler from USA, who popularized direct anterior approach without a special table using a regular table. Let me confess that I do not use any special table. I use a regular table that is available in majority of our hospitals. And the position that we may have to give in many times is called as a kidney position. That means the head is into a head low position and then you drop your leg into extension. So whichever is the table that you use, a special table which was developed by Olmata or a regular table which we use normally, the basic principles do not change, the basic dissections do not change. So we do this in supine position with, even if you are doing a unilateral total hip, I would advise you to drape both the legs. I use a bilateral O drape that we use for a knee replacement, because that makes life very easy and I can go right above the anterior iliac spine. I cut the elastic portion of the O drape, and then once I expose my DA, I usually mark all these lines and then put my IO band or the next thing in. So it's a pure internervous intermuscular pain. It goes through the sartorius and the TFL. And that's how you look at the sartorius and the TFL. You can very easily and clearly see the distinctions in the color. The sartorius is a bluish looking tissue underneath the fascia, whereas the TFL is a bluish looking tissue underneath the fascia, and the sartorius is the white structure in the front, which we probably appreciate better in the next videos that we have to follow. Once you have done that, you develop an interval between the sartorius and the TFL, and then you will come across minimum two perforators. Always remember there will be at least two perforators. In the last few cases, I have found out a few of my cases who had more than two or three perforators. So you need to identify them and ligate them really very well, or you have to cauterize them. Once you have identified and ligated your perforators, you will get the reflected of the rectus, which you need to take out and then take a napkin ring osteotomy. And after the napkin ring osteotomy, what you need to do is dislocate the head. Once you dislocate the head, then you go ahead and do a pubofemoral release. And then this is how we normally are not used to see this pubofemoral ligament, or we do not give much of importance to the pubofemoral ligament. Also is important is the iliofemoral ligament, which is on the superior side, which helps you to get the femur up or into your wound when you are doing a direct anterior approach. So you need to release both of these ligaments before you actually start and proceed with your approach. So I have a short video. I think that's a much easier way of explaining this approach. So we have taken the patient in supine position. We have drawn all the approaches. Here we have done a bikini incision. Yes, bikini incision. I do a lot of bikini incisions. The reason is it is a much more cosmetic incision. It heals much better than a vertical incision is what I feel. Instrument which is normally not kept into the armamentarium of arthroplasty surgeon is the Cobb's elevator that you borrow from your spine friend. So here I was demonstrating the two different colors of the muscles. You cut only the fascia and then use either a cocker or forceps to hold that fascia up, and use your finger to isolate the muscle or reflect the muscle from all that fascia underneath. So once you use your finger, you're 100% sure that you are not damaging anything, the structures or the muscles. Once you release that muscle from your fascia, you use a right angle Langenbach retractor onto the TFL and one onto the sartorius and start retracting. And then you will come across two big perforators. You have to hunt for them. Majority of the times, as I said, you will find two of them, at least two of them, maybe sometimes you might find three. So here I think you can appreciate the perforator really very well. So as my friend Rohit always says, you need to literally burn that perforator really very well. And once you you burn the perforators, use the muscle which is on the top of my elevator is the reflected head of the rectus. Underneath is the capsule. What you do is you aim for the opposite side kidney when you are actually taking out the reflected head of the rectus away from the capsule. One again easier trick is I flex my hip a bit so that I can very easily see my reflected head of the rectus away. And once you have done that, you put these three retractors. There are some special retractors available from some companies, and they are called as a Cobra retractor, which makes life really very easy. And that's the capsule which is exposed after you have taken out all the reflected hair of the rectus away from the capsule. And now here I have retained the capsule. Nowadays, I do a complete capsulectomy rather than a capsulotomy. It makes my life really very easy. This was a case of a neck femur fracture where we were doing a direct anterior approach and total hip replacement. So here you can see the head neck junction really very well. As I rotate my leg, you can see probably the fracture neck femur that is there. So there it goes. That's the neck femur fracture. And then in normal case, this is the first osteotomy that I would be doing. So once you rotate the leg, you get the neck out into the wound. And that's the napkin ring osteotomy I was talking about. It's a second osteotomy done. The first osteotomy is like a subcapital neck femur fracture where you do it really at the junction of the head and neck. and the second osteotomy is done around a centimeter from there. That makes life easy for dislocating the head. Then I use a power reamer for putting my corkscrew inside, and then you use your T handle and make sure that you keep on rotating the head in one direction for at least 10 times. Before you rotate it 10 times, so that all the capsule and the ligament inside, ligament teres, is broken and it is easier to take it out. Do not try and dislocate the head without you have actually turned it multiple times, and it is very easily rotated inside the acetabulum. Once you start dislocating, ask one of your assistant who is standing on the other side to hold on to the pelvis so that you can easily get the head out. This is the pubofemoral ligament I was talking. I use a hook to pull my femur away, and one retractor is placed onto the neck, and then you start gradually releasing the pubofemoral ligament. Once you release the pubofemoral ligament, it is very easy to get the femur away from the acetabulum. That's a special retractor that you need for a DA, which is called as a double prong retractor. And there you start releasing the superior capsule. A small practical tip is, after you have released the superior capsule, you will suddenly get a pop of your femur away from the acetabulum. So once you are done with the superior capsular release, you change your double prong retractor towards the posterior column, and that's how you get a fantastic view of your acetabulum, which is called a 360-degree view. Contrary to the majority people who might feel that how is the acetabular exposure, acetabular exposure is always a very nice exposure in DA. The problem is getting the femur into the wound, and I'll show you how to get the femur into the wound, which is very easy. The inferior retractor, or the retractor which is on the posterior side and the inferior side, are going to help to get my acetabular reamer in and out. Here you can see, probably this is a few of my old videos where I am holding my capsule back. One again important advantage of this particular approach which I have found out is I can use a C-arm image intensifier intraoperatively to be 100% sure about my placement of the cup and my leg lengths. So this is a trial implant that I have used in this case. Nowadays we have shied away from trial implants. The last nice AP capture that I'm going to get onto my reamer in osteoporotic bones particularly, I would not be going in for a trialing. I will rather directly go for my final implant. So that's my final implant, which goes inside and sits on very well. Again, a practical tip is you are doing a direct anterior approach, so your anteversion on the acetabular side has to be a little low. You cannot control your anteversion on the femoral side, but the anteversion on the acetabular side should be around 10 degrees maximum. So that's how your acetabulum should look like. Go inside the complete acetabulum and holding on to well. Majority of the times in a case of DAA, I end up using around 6 millimeters thicker acetabulum compared to, or a larger acetabulum compared to my head size. Majority of our company people will not keep a head gauge available when you're doing a direct or you're doing a total head. So make sure that you have that inside. Here I am demonstrating how to get my femur out. So if you notice, the leg is dropped and I have also given a head low position to the patient. And instead of going right into the lateral side of the canal, what I am doing is I am first entering into the mid portion of my neck, and then I use a rat tail, which is a special instrument meant to identify where is the neck actually going. And once I've used the rat tail, I know where my neck level is. And then I start broaching one by one, gradually increasing and dilating my canal. You need a special double angle broach handle for this. If you don't have a double angle broach handle, it is very difficult to almost impossible to go into the femoral canal. And once you have done that, you take a trial. So one practical tip is, whenever you are taking a trial, make sure that you pass one suture, usually a vicryl stitch, onto the head, because it is not unknown to get that head stuck under the rectus. Here you can see that I am putting a vicryl stitch onto my head, so that if by chance it dislocates inside from the taper, it is easier to retrieve that head. Otherwise, it is very difficult to retrieve that head once it goes underneath the rectus femoris muscle. So once you do that, you lift up the rectus femoris with one of your finger. As you can see that I am putting my finger in to lift my rectus and then pushing my head down. And then you give lateral traction, you give distal traction and internally rotate the leg to reduce the hip. The biggest advantage is you can see all the possible parameters and check whether your legs are perfectly equal. You can do these tests, or you can do GANS tests that's done usually in pediatric patients. You can see whether your stem is properly sized. And also you can see if you have a 9 inches high frequency C-arm, you can see the level of your lesser trochanter. I usually keep my legs into axial rotation to see whether I have a perfect leg length equality on both the sides. It's a very good idea to see that, especially when you are doing a single side THR. Whereas if you are doing a bilateral THR, you can correct the opposite side with the same length. So just a few case examples where we have done a DA in the recent few days. So a bilateral total hip patient was advised a conservative treatment initially, but wanted to get good pain relief. So we did a bilateral total hip in a single sitting. So one side total hip replacement was done. This was a case of a juvenile rheumatoid monoarticular, where we have done THR on a single side with a DA. Again, this is a patient of a rheumatoid arthritis where opposite side was already done by a posterolateral approach, and this patient wanted to have a direct anterior approach on this side, where we did THR on this side. A neck femur fracture where we have done a direct anterior approach with THR and maintaining the leg lengths equally. Here again, this is the same case that we have demonstrated in the video, where we have done a bikini incision. So in conclusion, yes, the dislocation rates are definitely much lesser in the last 1.5, 2 years that I am doing a direct anterior approach. I have not encountered a single case of dislocation. Definitely more precise limb length equality is achievable. Faster recovery, yes, majority of my DA patients, I make them walk on the same day. I let them walk without a walker in a week's time, and without a crutch or without a stick in 15 days time. I let them sit cross-legged on the couch or on the sofa within 3 weeks, and I do let them sit down on the floor or squat after 3 months. So I definitely advise you to learn this beautiful approach of doing a direct anterior approach. It definitely has a steep learning curve, but once you master it, it's a wonderful approach where you can probably give perfect leg lengths. You can give much more stability, and the patients are much easier. It's easier for the patients to recover and go back to normal function. So, Neeraj, if you have a few questions on this, I would take those questions.
Yes. I'll just stop your screen share.
Sure.
So, say, for example, a person who's very regularly doing DA and he wants to start doing regularly doing posterolateral, and he wants to start doing DA, what would you advise? Shall he start with a fracture neck femur bipolar, or should we go with a AV and rheumatoid arthritis?
See, if you're not used to do DA, bipolar is a big no-no for DA, because reducing that bipolar head is going to be a difficult job, particularly when you are not used to do a DA. So if you are planning to start DA anew, there are a few tips that I can probably give you. The first tip is make sure that the patient is not very fat. Second is make sure that the neck shaft angle is minimum 135. Ideal is whenever you are doing with a valgoid neck, the valgus is a better choice. After you have probably done more than 50 days, you can try for a varus neck, but in the initial days, you should try and do it for a valgoid neck. Patient should be lean and thin. Muscular patients, fatty patients is a big no-no. Over a period of time, what I have realized is a fatty patient is okay, but the patient who are muscular, the patients who are doing a lot of physiotherapy, or those who are bodybuilders, a DA is a big problem, particularly reflecting the rectus out of the capsule and maintaining it there becomes a big headache. And because of a lot of pressure coming on from the muscles, you do get that anterior spike pokes inside the acetabulum from the anterior cortex. So in the initial days, make sure that you are doing a lean and thin patient. Make sure the neck shaft angle is 135 or it is a valgoid angle. And one small trick again is you draw the canal axis, and if that canal axis crosses either lateral or from the ASIS, that is the ideal case. If that canal axis is passing medial to the ASIS, that means you are dealing with a virus snake. Then in the initial few days, it's a big time no for if you're doing it.
Okay. The fear of the anterior is always the femoral neurovascular bundle. So
Correct.
have you encountered any complication related to neurovascular problems?
No, we have not encountered any problems with the neurovascular bundle. Again, a small trick that I would tell you is flex the hip around 20 degrees before you start getting the reflected head out. Once I never use any sharp instrument when I'm actually taking out the reflected head from my capsule. Then I use a very blunt type of a retractor, which we normally use in the Cobb's retractor that we normally use in our spine. I always make it a point that I pass my finger underneath the rectus and palpate if there is anything left underneath the rectus before the capsule, before I put my any spike in, either a blunt spike or a sharp spike. Never put a sharp spike in without putting your finger and palpating, because if you are there and if you palpate, you are not going to miss femoral artery. So palpate before you put your spikes in.
Hello. Yeah. So the next question uh, is in ankylosing spondylitis, where sometimes their differentiation, making the differentiation between the head and the acetabulum is very different, and you have to remove the head with a reamer or a piecemeal. Is DA recommended or posterolateral approach recommended?
Uh, I would probably do a posterolateral approach still in ankylosed hip, because I am more comfortable with the posterolateral approach since I'm doing it for around 17, 18 years. But people have done DA with for a fused hip, and at times it becomes easier after you do the first subcapital osteotomy and then use a CRM image intensifier to know where your exact acetabulum is. But I would be skeptical of doing a direct anterior approach for a fused hip, not for an ankylosing, but for a patient who has a fused hip.
Now, you say that DA is not old. You are right, because when I was doing my residency under Dr. S.S. Ugrankar in JJ Hospital, he used to do something like an anterior approach, but this was not a DA. I think he was doing something like a Watson-Jones anterolateral approach, which was taught in UK very well, very much at that time.
Correct,
Is
correct.
it the
They
same
used
or is it different?
It's a similar approach. It's more like a Smith-Peterson approach, where we have cut down the approach which goes to the ASIs. It's a smaller approach compared to a Smith-Peterson. Watson-Jones takes a similar approach, but not the same as the DA.
Okay.
So earlier they used to do Watson-Jones more regularly, as you correctly said. Watson-Jones was more popular in the UK. So all those surgeons who were trained in the UK, they were doing Watson-Jones. They were doing it in supine position. Although a lot of surgeons were doing Watson-Jones in lateral also. But again, the dissection was far too higher in Watson-Jones compared to a direct anterior approach.
So one sentence which actually stuck to me is that why he used to tell me that why you should not take. In fact, there was a surgeon from Pune only. I forget his name. He was in KEM
Vaknis,
Hospital, Pune. He used
Dr. Vaknis.
Wagnis, yes. He used to say
Yeah,
that the capsule, posterior part of the hip capsule is the strongest part, and why we are cutting this. That is why we should always go anterior.
correct.
And I feel that is the right rationale. Is it the right rationale for doing the direct anterior approach? Less number of dislocations?
Yes, probably the posterior capsule is the strongest one. Second is when
Hello?
you're actually
Yeah.
going onto the floor and getting up, you are putting a lot of forces which are going to translate towards the posterior side. And if you have an intact posterior capsule, the dislocation rates reduces drastically. One question which has come into the chat is by Sachin Karkamkar, that why do I reduce my antivergence to 10 degrees and not go into the native acetabular antiversion? Is because I have gone from the anterior side and now I wish to reduce my antiversion on the femoral side to a lesser, on the acetabular side to a lesser degree, because I am not able to control the antivergence on my femur as in uncemented total hips. The antiversion of the femur is being decided by the native neck. So I can control only the acetabular antiversion, and thereby I reduce my antiversion so that there is no anterior instability after doing a DA.
The most fascinating part I feel is that the chances of the cup being too horizontal or too vertical are almost gone because we are checking under C-arm before putting it. So the cup version
Absolutely.
can be very well accurately adjusted as much as we would
Absolutely.
like. Yeah, compared to the posterior approach where we have to do a lot of eyeballing or use a robot.
Correct. So nowadays we have started using Robo also with the direct anterior approach. And after the introduction of Robo, we have shied away from the CR because with the Robo, I can be 100% sure about my inclination and antiversion. I don't need to use IITV to check my antiversion or inclination. But before the Robo software was available to us, we used to check it under the CR. Also, the advantage of Robo is the leg length, which we are actually arbitrarily checking on the medial malleolus and the tibial tubercle or on the by Gans test. Here, the Robo can actually tell you how much medialization or lateralization have you done, how much is the leg length that you have gained or shortened. So, use of CR over a period of time is going down because of the Robo. But if I don't have Robo at disposal, then I'll definitely use a CRM before I finally bang my cup in.
I think that's all for tonight. Thank you very much, Dr. Abhijit, for answering all our questions. And it was a fantastic video taking us through the anterior part of the hip, where the orthopedic surgeon, the general orthopedic surgeons dare not go. So we thank
No,
Dr.
no,
Abhijit.
I absolutely would like to say that everyone should try this approach, and it's a fantastic approach. Probably 5 years down the line, majority of the hips in India would probably be done by direct entry approach, as it is done in the US. I think 60 to 70% of THRs in United States are being done by DA nowadays.
In fact, US, there is also something called as a AHF, Anterior Hip Foundation, which promotes this approach very much. And OrthoTV is in the process of collaborating with them. And let's hope to see you there in one of the webinars where we'll have a great discussion on DA.
Sure,
Thank you
sure.
very much, Dr. Abhijit.
Yeah,
And
thank you,
thank you,
Neeraj.
viewers, for joining us today. Thank you, Haleon, for bringing us to this webinar, the makers of Centrum, Joints and Mobility. Thank you,
Yeah,
everyone, and
thank
good night.
you.
Marishi, stop.
Okay, sir.